Hi, I'm Dr. Tom Field, and I'm going to talk about neurocognitive disorders. From a biopsychosocial framework, neurocognitive disorders have quite a strong biological foundation. For example, tau tangles and amyloid plaques are things we're going to cover in a few minutes. You should also note that neurocognitive disorders can be genetically influenced. In terms of the psychological factors, lifestyle behaviors can play a protective role to an extent, though you should also know that other psychological factors, such as attitudes, beliefs, and values, often have less of a role in the development of a neurocognitive disorder. In terms of social factors, certain socially endorsed activities are known to enhance the likelihood of head trauma, such as contact sports. And so we should just be aware of this, that there are socially sanctioned activities, right, that are associated with neurocognitive disorders. You should also note that in general, we are living longer as a species. The rates of neurocognitive disorder, especially major neurocognitive disorder, increase from 1 to 2% at age 65 to 30% at age 85. So we're going to talk about major neurocognitive disorder, mild neurocognitive disorder, delirium, seizures, conversion disorder, and head trauma. Note that these conditions are often frightening to others in a person's social group because they can be associated with significant change in personality and behavior. At times, there is a loss of consciousness or memory loss, and often memory loss associated with this. Some of these disorders are chronic, progressive, and degenerative diseases, such as Alzheimer's disease. The prognosis is poor. Rarely, if ever, is a functional recovery achieved. Others are more acute and short-term, such as delirium. Medical intervention and consultation with medical staff is essential in these disorders, and the counselor often has a role in working with the family. I'll note here less of a role in intervening with neurocognitive disorders directly, right? In other words, individual psychotherapy for a neurocognitive disorder is going to have a marginal impact. We should talk first about the effects of typical aging and the things to understand about cognitive decline more generally. You should know that all of us, as we enter into older adulthood, experience some degree of cognitive decline. The extent of that varies quite a bit. Why does cognitive decline happen? Well, we tend to lose neurons as we get older. There's volumetric change, whereby the amount of new neurons being produced relative to the amount that are decaying, dying, is not proportional, right? And so you tend to see some reduction in brain volume. In general, the last brain structures and regions to develop are the first to go. For example, the frontal lobes are one of the last to fully myelinate and develop, and so they're one of the actual first to decline, associated with things like complex attention, but also with reasoning, problem solving, those types of things. You also see, as we've mentioned before, with volumetric change, loss of neurons. You also see dendritic spines be reduced and the number of myelinated axons be reduced. Default mode network connectivity can also decline. Remember, that's the connection between the prefrontal cortex, particularly medial prefrontal cortex, and the posterior cingulate cortex. And this has implications to working memory. So what are tau tangles, you might wonder? You've probably heard that term before. A tau tangle is essentially when the axon of a nerve cell gets tangled, right, and doesn't function properly, doesn't function as well as it typically would. And so, for example, information that is received down the axon, the electrical impulse that is sent down the axon, that kind of electrical process is impaired to some extent. Note where amyloid plaques are on this graph or picture. Amyloid plaques exist in the extracellular space and take up that space, and so they take space away from things like glia, right, which have a supportive role in terms of neural functioning. Remember, glia help provide nutrients to cells as well as help keep them in place, etc. And so the plaques get in the way of that. This is a actual picture of what an amyloid plaque looks like under a microscope. Interestingly enough, tau tangles and amyloid plaques are signs of Alzheimer's, though can also be found post-mortem in persons who are asymptomatic, who do not present with neurocognitive challenges. We don't completely understand why, right, that some people do and do not have manifestation of neurocognitive behavioral type responses and memory loss, for example, and others don't. But it's worth noting this, that there is that finding out there in the literature. So we're going to look at an example of advanced Alzheimer's to try to understand what's happening in terms of volumetric decline. Okay, and I'll warn you that these images, they're not the most heartwarming. They're hard to sit with, and they're, because of the amount of damage and shrinkage that occurs. So this is the first image. You see that the cortex has shrunk, right? Has shriveled. It has lost volume, right? And you also note that there are larger areas of ventricles, right? In other words, there's more space, empty kind of space that is filled with cerebrospinal fluid. Note too, the hippocampus really does reduce in size quite a bit in Alzheimer's, which helps explain memory loss. This is another image to kind of further explain this. You see the ventricles there are enlarged in a person with Alzheimer's. Note that the areas associated with language also decline, and with memory, right, the hippocampal areas. This is another example similar to what we've seen before. Yet another example, you can see the ventricle differences there in Alzheimer's. And, to give you an idea of what's happening, if you were to kind of see inside a person's head, if you will, the brain reduces quite a bit in size. And you see more ventricle, larger ventricles. So that's what's happening inside the brain, right? You get this volumetric decline and loss, especially in areas associated with memory. And what we also note is that muscular degeneration also occurs as we age. What does degeneration mean? Well, the muscles lose strength, right? And you can lose muscle tone, etc. Okay. This has important implications for the sensory system. For example, eyesight. A person may need corrective lenses when they didn't before. Hearing, they may need auditory aids where they didn't before. You can also see in terms of a person's overall movement that there are problems with coordination, right? And so you see problems with driving. You also see problems with falling. A person may be at a greater fall risk. And in addition to just falling in general, a person may may be more fragile in terms of their bone density and may have, for example, easier breaks and of bones and dislocations. You also see a person be more vulnerable to inflammation as they age. Quite notably in post-operative states, a person is more likely to have a more significant response to the inflammation that happens post-surgery, and they can develop delirium post-surgery. The rates are a lot higher as you age for post-operative delirium. You have a greater risk of this too if you have Alzheimer's. And this helps us understand a little bit too about why for something like the coronavirus, a person who ages, who's older, is at more risk, of more significant impacts of the coronavirus because of their sensitivity to inflammation. Okay, now let's take a look at major and mild neurocognitive disorder. This used to be called dementia. The key symptom is cognitive decline. There is the difference between major and minor is major is significant decline, minor is modest decline. In major neurocognitive disorder, the decline interferes with daily activities, whereas in minor, it does not interfere as much. For major neurocognitive disorder, there are two specifiers, probable and possible. The reason they have this specifier is that sometimes you can determine with some degree of trustworthiness, through things like lab-based measurements, especially things like brain scans, whether or not a person has a neurocognitive disorder. Other times it's less easy to do this. When you have a neurocognitive disorder that is allied with a medical issues such as traumatic brain injury, you would also include the medical code in the code. And the specifier is with and without behavioral disturbance. Now, behavioral disturbance, of course, we often think of verbal and physical aggression, and this can be particularly challenging for caregivers at home. Okay, you see all the coding there. The subtypes are listed on the right-hand side. I'll pick out just a couple here to note. Alzheimer's, you're probably very familiar with. Remember frontotemporal, that's the connection between the frontal lobe and the temporal lobe, meaning things like, for example, the amygdala, the hippocampus. And there may be a problematic connection between the two, right? And a difficulty with regulating emotions, for example. Traumatic brain injury, you're familiar with that. Note Huntington's disease down the list is associated with the ongoing loss of neurons over time. Some of these are quite medical based conditions, and you'd need to read up more about them in the DSM-5. Okay, we're going to talk about the way in which neurocognitive disorders have an impact at a major neurocognitive disorder versus mild, for you to differentiate the two a bit. Okay, we're going to look at several areas. Complex attention, this means sustained attention, divided attention, selective attention, and processing speed. Executive functioning, planning, decision-making, as well as working memory, right? Overriding habits and mental flexibility. Learning and memory, immediate memory, long-term memory, and then implicit memory, sometimes called preconscious memory. Language, expressive language, fluency, naming, grammar, and syntax, the spoken word, if you will. And then receptive language, right? The ability to comprehend what others are saying. Perceptual motor abilities, understanding one's kind of location in space and being able to move around in space. And then social cognition. This really has to do with a kind of emotional recognition, things like empathy, theory of mind, the ability to understand how others are thinking and feeling, right? And one's impact on others. We'll begin with complex attention. Let's look at the difference between major and mild. Major neurocognitive disorder, you see difficulty with a lot of stimulation. In multi-stimuli environments, the person is easily distracted, right? And they may be unable to attend unless the input is restricted or simplified. So if there's a lot of noise going on in the environment and a lot of visual stimuli, the person may be unable to attend fully and may need to be removed to an environment that is less stimulating. The person may have difficulty holding on to or reporting new information. They may struggle with performing mental calculations. And when they are processing, it takes longer than usual, and components have to be simplified to be processed. Okay? So you can tell that, for example, a person working at an employment setting, this could be actually quite a challenge to be able to attend when, with all the stimulation happening, it's very difficult for the person. In terms of mild neurocognitive disorder, the person is able to perform tasks that they were able to do before the onset of the symptoms, but the tasks take longer than before, and they begin to find errors in routine tasks. Thinking is most effective in low stimuli environments. They can exist and work in those environments, but they are less effective in those environments. So that's complex attention. Executive functioning. With major neurocognitive disorder, the person just abandons complex projects and they can only focus on one task at a time. They also need to rely on others at times to plan activities of daily living, meaning things like showering, cleaning their space or house, and making decisions. With mild neurocognitive disorder, the person is able to multitask, but it requires increased effort. They sometimes have difficulty resuming an interrupted task, right, and picking up where they left off, and may experience increased fatigue in planning, organization, decision-making, and tracking conversations. In other words, they get tired more easily, and they may note that and say, I'm quite tired. And family members may note what they didn't seem that tired before with doing things, that required this degree of organization. Learning and memory. For major neurocognitive disorder, the person struggles mightily. They may repeat themselves in conversation to try to remember. They cannot keep track of short list of items or plans for the day. And they may need things like written instructions or a written list of tasks that they carry around with them, right? Frequent reminders to pay attention to the immediate task. For mild neurocognitive disorder, the person does have difficulty recalling recent events and does rely on calendars, but they're more independent. They don't require prompting from others. They reread written content frequently. They may occasionally repeat self, but generally not within the same conversation. And that's important to note diagnostically. If a person repeats themselves in the same conversation, that's a major warning sign. If they repeat themselves across sessions, it tells you it's still a warning sign, still an issue, but perhaps not as significant. They may also lose track of completed tasks or paid bills. What's interesting here is that autobiographical implicit memory are relatively preserved, that the person can remember who they are, their own personal history, the people around them, and how they fit into that history, right? But recent memory is more impaired. So they may have forgotten what happened yesterday, but they can remember in general the story of their life. Whereas major neurocognitive disorder, that is more impaired. The person starts to lose the ability to remember their own life story and life narrative. Language next. Major neurocognitive disorder is associated with major impairment with expressive or and receptive language, right? They start to use replacement words for things they can't recall, such as that thing, you know what I mean, right? In using general pronouns, he, she, rather than names, they. With severe impairment, they may not recall names of close friends or family. They also have idiosyncratic word usage, words that most people don't use, grammatical errors, spontaneity of output, and sometimes economy of utterances, like briefer statements occur because they struggle to put language to things. Speech stereotypy can occur. What that means is repeating the same kind of words over and over. Echolalia, repeating what others have said over and over. And automatic speech. When these things start to happen, they typically precede mutism, which is the person just stops talking. Mild neurocognitive disorder, the person does have word finding difficulty. They may struggle to find the word they're thinking about, and they may substitute general words for specific terms and avoid using people's names. However, they don't, in general, struggle with just putting words to their thoughts and feelings. They are able to hold a conversation, for example. It's just that specific words may escape them or the names of people may escape them. When they make grammatical errors, they have a more of a subtle omission or incorrect use of articles, prepositions, auxiliary verbs. There's a subtle change. Perceptual and motor ability. With major neurocognitive disorder, the person has significant difficulty with previously familiar activities and navigating familiar environments, right? They may, for example, go to a place they've been to many, many times and not recognize it. They also may be more confused at dusk, as changes in light can impact their perception, right? Because then even more they're confused about where they are and what they're doing. And you'll hear stories about a person who gets lost and starts walking around the neighborhood because they can't recall where their house was. Mild neurocognitive disorder, they may need to rely more on maps or others for directions. They may frequently use notes. They may find themselves lost or turned around when not concentrating. But fundamentally, they're not going to start, for example, wandering around the neighborhood, or they're not going to, not recognize where they're at. They may just need to be more reliant on directions. They may be less precise in parking. You'll sometimes see that their parking job is just not as great. And they use greater effort for spatial tasks, right? That, for example, driving requires a lot of mental effort, whereas for most of us, it doesn't require that much mental effort. We're usually able to think about other things while we're driving. Social cognition last. So with major neurocognitive disorder, we experience and we see quite a large change in social cognition. Behavior is clearly out of acceptable social norms. You will see things like a person walking down the street naked, or you'll hear things like people yelling or screaming at family members or friends, sometimes using quite vulgar language, sometimes being physically aggressive. A person may show insensitivities or social standards of modesty in dress, or political, religious, or sexual topics of conversation bring up inappropriate topics of conversation that are embarrassing in public to others. They may focus excessively on one topic despite a group's disinterest or direct feedback. They may make decisions without regard for safety. And typically, they don't have a ton of insight into these changes. A person with mild neurocognitive disorder have more subtle changes in behavior, it should say, or attitude, often described as a change in personality, such as less ability to recognize social cues or read facial expressions, decreased empathy and inhibition, and then increased extroversion or introversion can occur. I'll note here that most of this is more subtle, right? So there is something that feels a bit different, but it's not as abrupt a change as you'd see in major neurocognitive disorder. You can also see sometimes apathy or, on the other side, restlessness that seems, again, out of character. So what do we do about treatment planning? How do we help a person with a neurocognitive disorder, something that seems to be, not particularly responsive to counseling? Well, we obviously want to involve a medical professional and be working with them. In terms of prevention, how do we stop it from starting? If you're working with someone who's, let's say, in their early to mid 60s, and they ask you this question about what can I be doing, right, to prevent myself from developing a neurocognitive disorder? In general, novelty is really important. That research has found that novelty is important. And it's not just things like, when we talk about novelty, we're not talking about doing things like just being active or doing crosswords, or that it's often talked about that way. We talk about true novelty, visiting new places that a person has never visited before, taking adult learning courses that they've never received any instruction about before, learning new languages, something that requires concentration and attention, right, and forces a person to really engage the brain. And and novelty does that, right? If we move to a new place, for example, where we stay somewhere for, say, 2 to 3 weeks, we have to learn where everything is on the map. We've never been there before. It forces the brain to be much more active than it typically would be if the routine is very familiar. Behavioral activation is also helpful. Getting out of the house, joining social groups, exercise, physical exercise is quite preventative. So those are some things just to be aware of. Diet matters as well as sleep, of course, but I think in general, novelty is very important to be attending to. In terms of intervention and treatment, you are going to need to be communicating with medical providers. Psychiatry might be involved. Family systems work can be quite useful. Recruiting family member involvement, processing loss and new life roles. For example, a person at midlife may have their own children and they have to care for parents, right? And they become part of the sandwich generation. And helping a person to process that can be important, as well as providing them a space to talk about their own sense of grief and loss, and how best they can kind of orient their life around taking care of the person who's older while also having other obligations. And it can be especially complicated if the person they're taking care of, is a parent who they haven't always seen eye to eye with. Maybe they've been borderline abusive or what have you, and processing that can be very helpful. You should also help the family plan for ongoing and continued decline. The unfortunate reality is neurocognitive disorders are progressive. Deterioration occurs. And so if a person is being maintained at home currently, the question is, well, what are you going to do to make sure you can continue to do that? What kinds of changes need to happen, right, for you to adequately do that? Are there situations in which you can't do that anymore and you need something like a placement in more of a rehabilitation center or nursing facility, a skilled care type of place? Yeah, and just playing through when that threshold is for families can be quite helpful. Okay, so we've talked about major and mild neurocognitive disorder. We're going to talk next about delirium. Delirium has some similar features and can be misdiagnosed, misunderstood. So I'm hoping to help clarify some of this as we go. It is marked by a disturbance in attention And awareness and orientation, right? The person isn't aware of where they are and what they're doing. They may um, also lose consciousness at times. There can be a also disturbance in cognition, meaning that a person at times seems lucid, right? They're able to have a conversation with you. At other times, they seem very impaired, almost in a kind of psychotic state. The disturbance develops quickly and fluctuates during the day. So again, it's not as if they are only impaired like persistently throughout the day. They actually do have periods where they are lucid, where they can have a conversation with you, and other times where they have impairment. You're looking for evidence that the disturbance is caused by a medical condition or substance use typically. Okay? Medical condition means something like post-operative surgery. That's one example of this. Substance use, you can look at, for example, a person who is withdrawing from substances such as alcohol. For example, delirium tremens is often something we have to monitor during alcohol cessation. And the specifier is acute, hours or days, or persistent, weeks or months. It can be hyperactive, hypoactive, or mixed. Hyperactive obviously means that the person is fairly restless, agitated. Hypoactive, the opposite. Here is the coding for it. You'll notice most of the coding focuses on substance use because substance use really it can be quite aligned with delirium. So what do we do with delirium? We always involve a medical professional, always. With prevention, we would engage in a dialogue with prescriber at regular intervals. Typically, you're only going to be working with someone who's experiencing delirium in more of a hospital-based environment. They're not going to be able to be maintained at home. You want to plan out substance withdrawals carefully, and patient treatment might be indicated because of the potential for delirium to occur. When a delirium does occur, the person is usually in a crisis state, and so, as I mentioned, inpatient treatment may be required. If you are doing work with someone who has delirium in an inpatient setting, typically all you're doing is assisting with things like daily grounding techniques for alertness and orientation. CBT is often useful for this. So in other words, helping a person just to orient to what are the sounds around you, what are the sights around you. Can they attend? Sometimes they can, sometimes they can't, but it's that regular repetitive practice that can help. Before I move on, I just want to mention a little bit more about delirium. So the way to differentiate it from a major or mild neurocognitive disorder is to consider A, that these changes occur rapidly, that the onset does not take weeks and months for a person to develop delirium, whereas it can with a neurocognitive disorder, major neurocognitive disorder. And so the person may, for example, have memory loss, have consciousness, changes in consciousness and orientation and alertness, and those changes happen fast. And so that's one of the major markers that tells you it's probably more delirium. The other thing to note about delirium is that it can also be accompanied with some psychotic symptoms. For example, formication, the feeling of bugs or creatures crawling on the skin is not uncommon. And you don't tend to see that as often with a neurocognitive disorder. Okay, seizures and epilepsy. So this is obviously not a neurocognitive disorder per se, but it is worth talking about in relationship to changes to brain functioning and, and issues with brain functioning. Okay. So this is defined as excessive electrical activity, which in other words is hyper excited neurotransmission, way too much neurotransmission occurring. Okay. We've talked about how conditions such as bipolar disorder, you also think about this, but this is even more exacerbated. In general, 8 to 10% of people will experience a seizure during their lifetime, so quite a large number of people. 35 to 50% do have recurrence after their single episode, 75% after a second episode. Psychosis occurs in 6 to 10% of people following a seizure, and so obviously it's something to monitor closely. Epilepsy is basically a recurrent seizures, and typically unprovoked, meaning that not caused by an event such as high fever. Whereas you can just have a seizure that is caused by high fever, that when the fever goes away, the person doesn't experience a seizure again. In the graphic at the bottom right, you also see the measurement of seizure activity through things like EEG. Okay, provoking events. These are things that can cause seizures. Fever, as I mentioned, high fever. Concussion, alcohol withdrawal, dehydration, low blood sugar or salt, sleep deprivation if it's very significant. I'm talking like multiple days of not sleeping. Brain infection and tumors. Electroconvulsive therapy is basically initiating microseizures for a person. And then stress. Believe it or not, high levels of stress can also cause seizures. The types include tonic-clonic, focal, and absent seizures. You're probably most familiar with tonic-clonic, which is the uncontrollable shaking with loss of consciousness. This is the one we're most concerned about in terms of a person's overall medical health. Focal seizures is uncontrollable shaking, but without loss of consciousness, though this can also fluctuate. And absent seizures is a subtle momentary loss of awareness. The person seems to stare off into space, almost kind of zone out, and then eventually they may come to. In children, you can also see some of their control over different aspects of the physical body be impaired during this time. For example, they may urinate on themselves without meaning to during the absent seizure. 60% of seizures are convulsive, are tonic-clonic or focal. Average duration is less than 2 minutes for convulsive seizures, about 10 seconds for an absent seizure. It becomes a medical emergency at around the 5-minute mark, but if a person is having a tonic-clonic seizure, you want to just be monitoring that very, very closely, right, and helping a person not to damage themselves during it. So, for example, making sure that they're not in a place they could fall, maybe lying them down while this is happening. And also making sure that they're lying down on their side, right? Rather, because you don't want also problems to happen with swallowing tongue and things like that. And so, definitely major concerns and things that a person will often have treated, right? They'll be taking medication for their seizures. It can also impair, important to note this, things like driving, right? And things where you're operating machinery. Okay, well, let's talk about conversion disorder, which is basically, it's almost like pseudo seizures, really. And so we'll talk about what this means. It's not always seizure based, but that's probably the most famous version of conversion disorder. It is, of course, under the somatic conditions category. We did not cover this when we talked about anxiety and somatic conditions related to anxiety. Because in my mind, it's helpful to understand this in the context of seizures. So this is altered motor or sensory function that includes seizures, but other things as well, that tests indicate do not have a medical cause. There has to be a rule out of things like a seizure through things like an EEG before you can diagnose conversion disorder. As an example with seizures, a person may have reluctance to opening the eyes. Like if a person is having a seizure and a medical examiner comes over and kind of opens the eyes with an actual seizure, that the eyes would just open. If a person closes their eyes shut, it tells you that actually there's something else going on within the person. The symptom causes distress or impaired functioning that includes problems with employment or social functioning. And the specifiers are all based on symptom type. Weakness or paralysis. A person can feel paralyzed in certain aspects of the body, for example, or weakness, like difficulty with walking, for example. Abnormal movement. Swallowing symptoms, difficulty swallowing. Speech symptoms, such as slurred speech. Attacks or seizures. Anesthesia or sensory loss can occur. Special sensory symptoms or mixed symptoms. You also hear stories about people who, for example, were lying in bed for weeks or months at a time, feeling like they could not get out of bed physically, and there was nothing medically to suggest that they could get out of bed. And it's not depression that they're struggling with necessarily. The person may genuinely feel like, I cannot move my arms or legs. Okay. Specifiers are acute or persistent, with or without a psychological stressor. At times there is an obvious stressor that this is in response to. This is why we often think about this as related to the stress response system, and the person is overwhelmed by stress, and these symptoms occur in response to that stress. It could be traumatic stress. It could just be a really significant stressor, such as the death of a parent or something like that. And with conversion disorder, you can make pretty significant change there just by working with the person on identifying the stressor and how best to kind of cope and manage it, knowing that the person doesn't have full control over the physical, uh, you know, manifestation of their stress symptoms. So it's important to note that the person typically is not intentionally engaging in these types of behaviors. That would be different. That would be more factitious disorder. But they feel a loss of control over their sensory and nervous system. And so you're helping the person just to understand the linkage between, for example, the stress response system and these types of symptoms. Okay, so that's our learning about seizures and conversion disorder. We're now going to learn about traumatic brain injury, again, another form of neurological issue that can happen not related directly to neurocognitive disorders, though as you've seen that you can have a major neurocognitive disorder that occurs subsequent to a brain injury. There are several different types of brain injury. Contusions, which is the same as brain bruising. A brain injury, which usually involves some kind of volumetric loss or decline in certain brain regions or areas, okay, like significant damage to the neurons. And then chronic traumatic encephalopathy, CTE, as it's often referred to in the media. You're probably familiar with this. It's been talked about ad nauseum in relationship to contact sports, particularly football and boxing. CTE is all about repetitive minor kind of concussive blows, if you will, and the effect of that over time, that it causes brain injury, as you might expect from a major head trauma, such as what would happen during a car accident. I'll note here that not all blows to the head are damaging, particularly if it's a minor blow. For example, my kids run around and they fall down, they bump their head almost constantly, right? This just seems to be a function of childhood. Not a major fall, thankfully, but you know what I mean? They'll bump their head here or there. Typically, those types of bumps, like if you're another one, where, you hit the ceiling with your head by accident or whatever, okay? You're going through a door and you hit the doorway with your head. Not every time that you hit your head is going to cause damage. The reason is because the brain is actually attached to the skull, believe it or not. And so minor collisions do not necessarily result in injury. Okay, so you'd only see this really with a more significant blow to the head, more significant force. I'll note here that what we tend to see with brain injury is you see decline to the area of injury. So it could be, for example, the frontal lobes if a person experienced a frontal lobe injury. You may also see over time that there are problems with things like volumetric decline in other areas, that there's shrinkage overall. For example, you do see tau tangles in chronic traumatic encephalopathy or CTE, just like as you would with a neurocognitive disorder. You also see, as you can see here in this image, atrophy, shrinkage of areas, just like you with neurocognitive disorder. And you can see, for example, ventricles increase in size. Okay, we're going to do a very quick case study. I want you to have kind of pen and paper ready. I'll ask you to pause the video, write down your thoughts, and then I'll explain which of these is correct, just to process through some differential diagnosis here for a second. Okay, so imagine that you have a client called Jordan, a 7-year-old girl who is struggling significantly at school. She regularly forgets information, has spells where she stares into space for prolonged periods, is urinating through her clothes at times. She seems to have age-appropriate socialization skills, though. These symptoms are signs of which condition, in addition to potential trauma? So we have head injury, schizophrenia, seizures, and stroke as options. Pause the video and jot down your thoughts. Okay, so let's take a look at the potentials here. Head injury, schizophrenia, seizures, and stroke. So what we have learned so far is that forgetfulness, just memory problems, can be associated with head injury, not typically schizophrenia, so we can rule that out here, seizures, and sometimes with stroke, okay? Depending on the type of stroke, but it's pretty typical that they're going to have problems with forgetting information. However, we will note here that says regularly forgets information, not just post-stroke, if you will. So that doesn't make sense there. So we can also eliminate stroke. So now we have head injury or seizures as options. So just by playing this through and thinking about regularly forgetting information, that there are ongoing issues with memory, which makes most sense. Has spells where she stares into space for prolonged periods, urinating through clothes at times, but the socialization skills are intact. I'll note here that a person who stares into space, you wouldn't typically see this because of head injury. You'd see this because of seizures, especially absent seizures. So the one that seems to fit here would be seizures. And it says in addition to potential trauma. Why does it say that? Well, trauma, of course, can be associated with dissociation and forgetting information, kind of zoning off into space. That can all be associated with potential trauma. So that's another piece of the puzzle here. But if this person was presenting this way, hopefully you would refer them to a medical specialist to rule out seizures, right? Maybe to get an EEG completed just to make sure that's not happening. Okay, in conclusion, neurocognitive differential diagnosis can be a challenge, especially in older adulthood. Part of the reason for that is, for example, differentiating something like delirium from a neurocognitive disorder is tricky, and you have to be very attentive to how quickly the symptoms emerged and if there's any substance use in the picture or post-operative stuff. The other thing, of course, that causes delirium that you should be aware of is things like really significant inflammation, like you'd see with a urinary tract infection. In general, abrupt acute change in attention, consciousness, and memory indicates delirium, that abrupt acute change. Progressive declines in those areas indicates more of a neurocognitive disorder that occurs over time. You should also note that seizures can be misunderstood for ADHD, autism, and schizophrenia, the sense of, again, the absent seizure especially, right, whereby the person isn't attending. Note that seizures do often co-occur in autism, and so that also makes it complicated to diagnose because you may wonder, is it just the autism? Are they just, for example, engaging in a perseverative interest in attending to that rather than to their environment? Memory loss does often accompany seizures and can be life-threatening. The best practice for assessing seizures is EEG evaluation. We also talked about head injuries, which can leave lasting effects and lead to later neurocognitive decline. That concludes this video lecture.